6 to 7 months, which is adequate for me to consider him for a total correction, sir. I would like to plan for an intracardiac repair and possibly not do a tap. And in drop, I will decide if it is necessary or not, sir.
There are two things in this case we discussed last time.
Yes, sir.
I thought the Macron index was 2.2,
Yes, sir.
which is very good. Only thing is, I think there is one additional VSD.
Additional muscular VSD. Yes, sir.
So, is it a contraindication for a intracardiac repair or not?
No, sir. Once we have adequate resection of the right ventricular outflow, we will be able to close that additional VSD as well.
Yeah. So that's not a contraindication.
Yes,
Only
sir.
thing we used to say, multiple switches defect in a small baby may be a contraindication. And that we used to teach us one of the indications to do a palliative procedure, not just
Yes,
one
sir.
VSD.
Yes, sir.
Supposing you cannot see that other VSD, muscular VSD, what maneuvers will you do to visualize that?
Sir, preoperatively, TE will define the area where the shunting is happening, or a step-up maneuver if to confirm if the VSD is anyway significant or not, sir.
No, on table, so there are a lot of trabeculations in the RV. Sometimes
Yes,
the
sir.
VSD, muscular VSD is obscure.
Yes, sir.
So how would you like to, what will you do to visualize the area of that VSD?
The surface of the right ventricle is very, very rough. So you can't really differentiate between a trabeculation and a muscular VSD.
Yes, sir.
So how do you differentiate between a muscular VSD, and all muscular VSDs won't be large enough for you to just, identify with the
Correct, sir.
naked eye.
Correct, sir.
Yeah. So there are a few things, one or two things which we can do to identify that additional VSD.
You must be aware of that, otherwise you will miss it.
Okay, anyways, so there are two, three maneuvers what we can do. So
Yes,
you
sir.
can pass a right angle through the big VSD, through the big malaligned VSD into the LV, and through that you can try to probe the rest of the septum. Okay,
Okay, sir.
and see where, and you should be careful enough not to force it anywhere, because if you force it, then you will create a VSD.
Yes, sir.
Because where the right angle naturally comes into the RV, that is where your additional VSD is. So
Yes,
that
sir.
is one maneuver. Okay. But this is in case of a TOF where the VSD is large, where you can easily pass a right angle there.
Yes, sir.
Suppose it's like a perimembranous VSD where the VSD is not very large. It is not very safe to pass a right angle through that VSD. It's like a perimembranous. So in that case, what you'll have to do is you'll have to go through you have to make a large PFO, pass an instrument through the PFO, through the mitral valve, and then try to probe the septum from the left side. So
Okay,
what
sir.
we do is usually we probe the septum from the left side gently and see where you can see the tip of the right angle. And when you see the tip of the right angle on the right side, you pass a vessel loop through that so that you don't miss it.
Okay. Okay.
Okay. And then you so identify it, and then what you do is you finish the big VSD first, and then you finish the the bigger one, the
Yes, sir.
smaller one. Okay. And suppose and not all muscular VSDs are usually always visible. Okay. So sometimes what happens is once you close the big VSD, okay, now you've closed the big VSD and then you identify the smaller muscular VSD, you've closed that also. How do you identify if there are additional VSDs apart from, very simple.
Apart from these two, sir.
Yeah, apart from these two, just fill the left side.
Yeah. Yes, sir.
Just take some blood or saline or something and just fill the left side and see if there's anything coming on the right side.
Yes, sir.
That's
You
all.
can
So
even
and
give
then you
a
see
cardioplegia through that PFO vent
yeah,
catheter.
vent catheter. You can just put a vent there, ask him to give cardioplegia through that vent.
Yes, sir.
That will just fill the left side, and then you will see something coming, if it's coming or not coming or whatever it is.
Yes, sir.
Okay, and then you can decide whether to address it or not. Okay,
Yes, sir.
right. Yeah.
This is important, Karan. Don't
Yes, sir.
forget this
Yes, sir.
step, okay? Because as Dr. Sudeep said, with so many trabeculations, you can very well miss the muscular VSD on the in the right septum.
Yes, sir.
Okay, now go ahead.
Sir, I'll plan for the intracardiac repair. I'll start the surgery, sir.
Hmm.
Sir, the patient is painted and draped. Surgery is ready to commence. I'll approach through a midline stenotomy. Thymus is dissected. Innominate vein is identified. Pericardiotomy done to the right lateral side. Pericardial patch is harvested and pericardial well created with stay sutures. Visual inspection of the heart is done, sir. I will observe an enlarged RV, a small PA, and a large aorta in this patient. I will check if there's any coronary crossing of the right ventricular outflow tract. I want to check the relation of the aorta and the PSF. What is anterior and what is posterior? And if there is any wasting on the right ventricular outflow tract, which will signify infundibulary obstruction. Once done, I will do a systemic heparinization to achieve a baseline ACT of around 480 or 3 to 4 milligrams per kg body weight of heparin will be given. And aortic cannulation is done, sir. Concentric burstring on the aorta. SVC and IVC cannulation is done separately. Both cavae are looped and taped, sir. Root cannula is placed. And once this is done, then I will search for PDA. Before going on pump, I will look for the PDA, sir. If it is there, I will like it. And then I will go on bypass. I will cool the patient to a temperature of 32 degrees Celsius to
How do
28
you
degrees
how do
Celsius.
you search for the PDA?
Sir, I will
Yes.
search along the border of the left pulmonary artery. Medially, I will go superiorly towards the aorta, sir.
So the safe way to look for the PDA is to not to actually look for the PDA.
Yeah.
You go for the LPA. You go for the LPA, dissect the LPA out. Okay, so the LPA is in the safe. RPA is usually away. Okay, you go for the tissue between the RPA and LPA, and that is where you will find the PDA. Usually, because if you go for the PDA, you're going to rupture it.
We olden time we used to say
Yes,
we take
yes, sir.
stay sutures in the pericardium and put a
Yes, sir.
retractor there, retract that pericardium to the left shoulder. And we used to take
Yes.
a mosquito on the appendage of the pulmonary artery and pull it down and dissect that junction, carefully.
A- Absolutely, sir. We do the same thing.
Yeah,
Like, that is
yeah,
the gold standard now. Yes, sir.
yeah.
Okay, so suppose you're dissecting the PDA and you're a young surgeon, you're dissecting the PDA. What will you suppose? And the PDA ruptures now at this point. Okay, I hope it doesn't ever happen to you. Okay, I hope and pray that it never happens to you. But you're a young surgeon and you're operating and your boss is away. Okay, and the PDA ruptures. Okay, so what can you do to bail yourself out of the situation?
Jairaj sir will tell you the CMC technique.
Because it is very important. This if the PDA ruptures,
Hello.
What can you do? What is the simplest thing to do, Karan?
Sir, sorry, sir. I just got disconnected. I missed from Sujit sir telling about
Yeah,
yeah.
you
So
got
what I
your.
was
yes, from PDA, not to go searching for the PDA. I missed from there, sir.
okay,
Sorry,
okay,
sir.
yeah. So what we were telling is that So the best way to dissect the PDA is to not to exactly go for the PDA. Okay, just try to dissect out the LPA first, and then you know that the RPA is usually away. Okay, and then you go for the tissue uh, between the LPA and RPA. You retract the PA downwards, like the foot end, and ask the assistant to pull the adventitia up. Sorry, the pericardium around the aorta there up towards the left shoulder. So then you can gently loop it. Okay.
Yes, sir.
So what I was getting at was, suppose you're doing like an ICR and you're by yourself. Okay, you've just
Yes,
started
sir.
your surgical practice, your career in CTVS. Okay, and you're doing a TOF, and for some reason your boss is away. Okay, and while you're dissecting the PDA just gives way, and there's blood all over. Okay,
Yes, sir.
what can you do to bail yourself out?
Sir, immediately go on suction bypass and completely cool the
Okay.
patient
Hmm.
for the first thing, sir.
Okay.
But you can't see anything.
You can't. It's
Yes,
yeah, I mean, it's very difficult to, it's so difficult that there's blood all over. There's just blood, just aorta bleeding into the pericardium, basically. There's so much blood anywhere that you can't do anything.
so suction bypass and total circulatory arrest, sir. Would it help, sir?
The simplest things, the Jairaj sir will tell you the CMC technique. You are not listening at that time.
Yes, sir.
You pass a Fogarty catheter
Yes, sir.
through the hole, inflate the balloon, give a gentle tug that will stop the bleeding, and then you can either take a purse string or a
Or a pleasure
suture,
juncture.
whatever, and then close it.
Okay, sir.
Okay, go ahead.
Yes. Once the PDA is looped and ligated, I will go on bypass. I will cool the patient till 28 degrees Celsius. The SVC and IVC is now snared.
For the rest of the people and the juniors, why do you need to ligate the PDA? Soon after bypass, you said you'll ligate the PDA. Why? Come on, yeah, basic thing.
It will be return coming to the heart because of PDA.
Yeah, there is increased return, and then your visualization is going to be problematic.
Impaired. Yes.
Not only that, if you are going to do it under deep hypothermia circulatory arrest, even a pro-patent PDA has to be closed. Otherwise, what happens when you do circulatory arrest? Air can enter through the PDA and go to the brain also. That's why in deep hypothermia circulatory arrest, we always dissect out, and whatever it is, even if it's a poor patent, it has to be ligated, because the flooding of the lung may not occur when the PDA is very small, but it's critical in deep hypothermia circulatory arrest. Okay, all right.
Yes, sir. SVC and IVC is snared. I let the heart beat for a few minutes. Lungs off. Ensure that the PA is completely collapsed. Aortic cross clamp is done. Cardioplegia is administered. I administer Delnido cardioplegia at 40 milligrams per kg body weight.
ml.
I will 40 ml, sir, 40 ml per kg body weight. Went at the left side with a PFO, sir. I opened the right atrium and went the left side through a PFO. The right atriotomy is done parallel to the AV groove with the IVC just inferior. Retraction of the tricuspid valve, and now decision of what to do next to plan for an RVOT resection with VSD closure, and then assessment for transannular patches.
Okay, so before you actually go for the VSD and that one. So as soon as you cross clamp and give cardiopegia, and then so now you have to vent the heart, right? So once you open the atrium, you'll have to suppose there's so much returns that you're not able to see anything. Okay, which is usually the case in slightly bigger older tops. Okay, so this is sometimes there are so much returns that you can't see anything. Like the VSD is getting flooded, you can't see the VSD and you can't see anything. Like even the LA, whatever vent you put in the LA is not sufficient. There are a few things which you can do to improve your visualization, because
Yes, sir.
collaterals can be really troublesome in some situations.
Yes, sir.
So uh, so one thing is, if you feel that the collaterals are too much, then you can ask them to cool further. Okay, so you can ask them
Yes,
to
sir.
say go to 26 or even 24. So what will happen with that is, according to the temperature, they'll reduce the flows, so your visualization becomes better. Okay, that
Yes,
is
sir.
that is one school of thought. The other school of thought is to not cool, but to put additional suckers in the LA. Okay,
Yes, sir.
and also snare the branch PAs, like because you'll have lot of returns coming from the branch PAs into the right ventricle. So some surgeons also like to loop and snare both the branch PAs or clamp both the branch PAs at the hilum, so that you
Yes,
have
sir.
working bloodless field. Okay, because
Yes, sir.
if the collaterals are too much, then you won't be able to see anything. Okay,
Yes, sir.
yeah, yeah.
Yes.
Or sometimes you
Now
can just clamp. You can put, or sometimes you can put a cross clamp across both, another cross
both
clamp,
are, yes, sir, on aorta
aorta
and the
and PA,
PA. Yes, sir.
aorta and PA, so that
Yes, sir.
your returns get better. Yeah. Okay.
Next, I will proceed with my right ventricular outflow tract obstruction, a resection of those. We resect all those muscle bundles causing subvalvular stenosis and right ventricular outflow tract obstruction, sir.
What are the
Uh,
landmarks you should see before all this?
Sir, I would like to make sure where my VSD is, and we spare the area around the VSD near the aortic valve to take adequate sutures. We spare the margins of the VSD. We do not cut muscles that are attached to the tricuspid valve chordae, and muscles that are actually resected would be anterior limb of the trabeculoseptomarginalis, parietal bands, any abnormal attachments to the pulmonary valve, any infundibular muscle valve bundles, hypertrophied septal bands, sir. These are the muscles that may be resected to gain adequate relief, sir. Things
You
that are
you have
spared,
to you have
yes,
to
sir.
identify the muscle of Lancy and you have to
Muscle of
identify the
Lances, sir.
moderator band so that you
Yes, sir.
preserve these things and then
Yes, sir.
look for the trabeculoseptomarginalis.
Yes, sir.
So the dictum in surgery is think twice, measure thrice, cut once.
Yes, sir.
Whatever you do in any surgery. So that principle cannot be forgotten.
Yes, sir.
In this case, either a pulmonary valve stenosis, the annulus is okay or not. Suppose it's pulmonary valve stenosis also. What are you going to do?
Sir, I would first assess if there is if I can do I'll pass the Hegar's dilator according to the Rowley normogram. And if it passes, then it is okay, sir. If it is not passing, then I would try to do a small commissurotomy, nothing that is affecting the valve, and try to pass
You
the
will try to
Hegar's
do
again.
you will try to do a commissurotomy through
From where?
transcatheter hypothesis.
From where will you
What
do
sir
the
is asking
commission?
is from where will you do the commissurotomy? Your
I will
atrium is
have to
open now.
open the no, sir. I will have to do an infundibulotomy at
Yeah,
that time.
you got to do small pulmonary because what you find in most pulmonary stenosis is that all the commissures are fused together. Not only
Yes, sir.
commissures are fused together, that fused commissures is also attached to the pulmonary arterial wall. So you
Yes, sir.
can do or commissurotomy. Then you can separate this joint commissure to the pulmonary valve. So you can cut another 2-3 millimeters, which you cannot do. I know that surgeons try to do it from the transatrial, but you cannot do a satisfactory job. Then you
Yes,
pass
sir.
the. Sometimes after that also you can do some muscle resection, transpulmonary. Then you pass the. It's not a good thing pass just uh, through the tricuspid valve. Uh, it's always better if there's pulmonary valves, just to do a pulmonary arteriotomy, do a
Yes,
full
sir.
pulmonary valvotomy, release it from the
Yes,
pulmonary
sir.
arterial wall, then try to do pulsate.
Yes, sir.
The
What's the
cardiopulmonary,
difference? Sorry, what's the difference between pulmonary valvotomy and aortic valvotomy? Are you aware of that?
No, sir.
In aortic valvotomy, you don't go right up to the annulus. 1 millimeter before the annulus, you stop. Whereas in pulmonary valvotomy, you will cut across like a T-shaped incision along the commissure.
Yes, sir.
So that it opens up completely. So you must be aware of these things.
Okay, sir.
Okay, pulmonary
Yes, sir.
valvotomy through the pulmonary artery. Okay, fine.
Yes, sir.
Because especially if your annulus is good, a good size, you don't need to cut across the annulus. So that is
Yes,
the
sir.
reason why you can go from above and below. So
Yes, sir.
spare the annulus. But if your annulus is already narrowed, you can go across the annulus.
Yes, sir.
Go
very
ahead.
often the pulmonary valve may be bicuspid also. So
Yes, sir.
actually when you do a uh, TAP, actually you should not cut through the back cusp and all. You have to be trying to go through the commissures, so that you don't. Previously, we used to chop away pulmonary valve also to get a better, but that's all given up. Most people don't do that nowadays. To
Yes, sir.
actually make the pulmonary regurgitation minimal, so whatever cusp is it. Is it what you do nowadays, Sujit? I don't know.
Yes, sir. So most of the pulmonary valves in tetralogy at least are all bicuspid, sir.
Yeah,
Mostly bicuspid valves, and there is some amount of supravalvular tethering
yeah,
to the MPA. So
yeah.
first thing is we release that valve from the
Wall,
tethering. So
pulmonary
the valve
artery, yeah.
from the wall. So the wall from the valve drops down. That is one. And then secondly, like like Krishna sir said, we do the commissurotomy. We go till the annulus and go on either side also a little bit. So and also we'd rather have little bit PR rather than some gradient there. So little mild mild PR is all right, sir. But a gradient usually we try not to have across the pulmonary valve.
Mm.
And that is one way. And the other way, suppose we have a we have a ventriculotomy. We already have a ventriculotomy for some reason. So we can usually pass a Hagar through the ventriculotomy into the PA, or we can use an instrument like a duct dissector or a Dennis Brown, whatever, and try and dilate that the pulmonary valves. So two three
Yes, sir.
things. What?
I remember in the early years of cardiac surgery, Dr. K.M. Cherianmani joined the Southern Railway Hospital, Colombo. One day he
Yes,
is
sir.
trying to pass a Hagar. So actually, he's got the integral coach factory next door, you know. Next day, they produced a curved Hagar according to our
Yes, sir.
measurements,
Yes.
which was very
Right.
easy to pass from the right atrium through the tricuspid valve.
Yes.
So this is, I'm saying,
Correct, sir.
about 1972.
Yes, sir. Yes, sir. Yes, sir. So abroad, sir, they
Yeah,
don't use cigars like how we do. They have
yeah,
these small dilators which are just the length of the dilators are just about 1 centimeter, and the rest of
okay,
it is all malleable.
okay,
It's like a malleable stick,
yeah,
so you
sure,
can manipulate it either ways,
yeah,
and you can use it. Like even if you have to put it through the branch PS, you can
yeah,
manipulate it, make it like a right angle dilator, and put it in on either branch
yeah,
PS also. So this is what they use outside, but here we don't have it, sir.
okay. And the most important part, you come to the closure of the VSD. You know?
Yes, sir. Uh, I do the closure here with the Savage patch. We do the closure with a 5-o-proline continuous suture, sir. And I will first identify the landmark of muscle of Lancisi, which is the medial papillary muscle of the right ventricle. And then I decide to go clockwise and anti-clockwise, sir. As we progress anti-clockwise, we should be aware about the right coronary cusp of the aortic valve superiorly. And clockwise, we have to be checking about the pulmonary valve anteriorly. The conduction tissue is which is very postero-inferior, and then the septal of the tricuspid leaflet, sir, which is inferior. And we tie the sutures both at the level of the septal leaflet of the tricuspid valve, sir. And
Basically, they
com
used to start the first suture beyond the muscle of Lancisi, double armed with a pledget. You know, they don't do that nowadays. Eh?
No,
if
no,
we
we
are
still do
using a
it, sir.
pericardial patch,
Yeah,
sir,
the first. Okay.
No, it doesn't matter either ways. Whatever patch you
okay, sir,
use, the first suture,
should
what
be
you're going to
placated.
take, the
Yes, sir.
entire the only that is the only VSD suture. What if that
Yeah.
suture cuts through the muscle?
Correct, sir.
And so the essence is to not tie too tightly. The essence is to not kill that suture while tying the patch down. Just just right so that the patch is firmly seated, but not too tight as to tear through the muscle because that muscle is thick but hardly has no strength.
Yes, sir.
So
So
yeah, and then
from
you
there,
cut.
you go. What are the structures you pass from the muscle of the LCC? If you go to the left side upstairs,
Yes, sir.
the parietal band, what are the structures you come in sequence? Otherwise, what
Sir.
are the margins of a VSD in cytology? You know, that's a favorite question of some examiners.
Yes, sir. Sir, superiorly, there is the right coronary cusp of the aortic valve, and posterior-inferiorly is the conduction tissue. Anterior to us is the pulmonary valve, and then septal tricuspid leaflet is inferior, sir.
There used to be something
It,
called the
it
ventricular infundibular fold.
interventricular fold. Yeah.
Yes, sir. That is the most inferior most.
Normally, in the normal development of heart, it is the one which separates the pulmonary valve from the tricuspid. You know, in tetralogy, because there is a big malaligned VSD. This is small or uh, very small, sometimes even absent ventricular infundibular port. So after the aortic annular that comes VIF, then comes a septal leaflet, that
Yes, sir.
And all
olden
your
time,
bites. Yes, sir.
olden
Yes, please
time,
go ahead, sir.
we used to put either all interrupted projected sutures or interrupted projected sutures in the viable area in the posterior inferior where the bundle is, and the rest continuous. These are the techniques used to do in olden times, but now most of the surgeons do continuous suture. And only on the posterior inferior part, you have to be careful. You take the
Yes, sir.
sutures about 4 millimeter uh, below the margin on the RV aspect, that's why you take few millimeters below, so that it doesn't.
Yes, sir.
Okay.
So, and another thing is, you mentioned the right coronary cusp forms the superior border. If there is more override, it can be all coronary. You can see the
Okay,
entire
yeah,
aorta
Correct,
there.
sir.
yeah.
It can be
If
all
it's like
the
the if it's
cusps.
like a if it's like a DORB, you'll see the entire aorta there.
Yes, sir.
And and like even like as recent as like 5 6 years ago, or 7 years ago, when Dr. Balram used to take all interrupted, sir, at all the
Mm.
All India Institute.
Yeah, we all use
So yes, sir, like all interrupted, like he would not compromise at all.
with
So
blood jets,
I mean,
yeah.
it's with pleasures, and especially if
Mm.
it was a DORB, then managing 20 25 interrupted sutures would be hell for the first assistant. So,
What is the South Asian variety of VSD in tetralogy?
right, right, very important. Yeah, I was just getting to that, sir. The Mexican variety or the Nerito variety, what is it? How is it different from the regular TOF? In fact, I asked someone yesterday. I asked Divyanshi or someone yesterday. Anyone? So this is a variety which is mostly seen in the Southeast Asian population. Okay, so in tetralogy, what happens is normally there is a conal septum between the aortic valve and the pulmonary valve. Okay, there is some muscle there. Okay, so but in the Southeast Asian variety, so this is also called the Mexican variety. It is seen among Mexicans also. So there is no conal septum at all. In the sense, the VSD is doubly committed, and the aortic valve and the pulmonary valve are in continuity. So that is what is the Southeast Asian variety, the Nerito
Mm.
variety. So your patch will go in between the annuli of the aortic valve and the pulmonary valve. And if it's this kind of a TOF, it will almost always 95% will need a tap because there is almost no conal septum. And so the VSD is so large that the pulmonary valve is like very, very diminutive. So you will almost always need a tap in a patient with a Mexican variety of TOF.
Yes, sir.
Yeah, we used to take sutures from the pulmonary aspect those cases because from the translated, I thought it used to be difficult, so
Yeah.
especially if you're
Yes,
going
sir.
to put a tap, you can take sutures a better under vision from that. Usually in the
Yes, sir.
textbooks, they say in Western countries, this is only about 5% of the technology, whereas in the Far East, even up to 30% of them may have this type of uh, doubly committed VSD. Okay.
Yes, sir.
How do
What's
you
the
know you have
percentage of? Yeah, sorry, you go.
no? How do you know you've done a good job?
Sir, once I finish the resection, I will pass the Hegash dilator according to the Rowley normogram, sir. But later, once coming off from, I would measure the PRV-LV ratios, but intraoperatively, this is how I would ensure, sir. And my pulmonary valve should be completely visible when after my resection.
We used to say because it's under cardioplegia, you give one size more than the nomogram, because it's,
Yes, sir.
what incidence of complete heart block and what are the other blocks? In Narayana area, we say the complete heart block is less than 1%. What are the other arrhythmias, heart blocks you find after correction of pathology fellow? Most common.
So, a complete heart block incidence is less than 1%.
Yeah. What's the most common that I'm asking? Right bundle branch block. Why hesitate that? When we
Yes,
used
sir.
to do right ventriculotomy, it used to be as high as 90%. Even transatrial, it's almost as high as 50%. So many of them may have a right bundle branch block.
Yes, sir.
And what else? Another dangerous one is RBB with left anterior hemi block. How do you diagnose RBB with left anterior hemi block? As a surgeon, not an expert cardiologist, how can you diagnose a patient post-operatively has got a RBB plus left anterior hemi block? Normally, what is the access in QRS access in pathology of allo? Normal.
So there are visible Q waves in the inferior leads, and
When I'm asking, easiest way to find out RBB with left anterior hemi block. Normally, what is the access in pathology?
normally it is right axis deviation, sir.
Right axis. So preoperatively, if the patient has got a right axis deviation, and after operation you find left axis deviation, you have made a left anterior hemi block. That's the commonest and easiest way to detect whether you have made because if a patient has got RBB plus LH, they have to be followed up because many of them may go into complete heart blocks. Okay.
Yes, sir.
So RBB is very common.
Yes, sir.
The other important thing is you should also make sure before you come off to make sure that there is no residual VSD.
Yes, sir.
Incomplete resection of the RVOT and residual VSD are the commonest causes for reoperation.
Yes, sir.
How will you check for residual VSD?
One is with the help of the TE, sir. Second thing, if we have the residual VSD, we take this. We do something called as a step up, sir, where we simultaneously take 2 cc blood from the pulmonary artery and the right atrium. We check the gas analysis, and if RA and PA both are desaturated blood and are of same saturation levels, this is okay, sir. And if the step up is what we call, if the saturation in the PA is more than 7 to 10% of the right atrium, then this is a significant residual VSD and we may have to go up, sir. Go back and search for it, sir.
When you answer in the exam, just for this thing, Don't say what we call this and what we call that. Your examiner
sir.
is much more experienced than you.
Yes, sir.
Okay, just say step up across this thing. That's it.
Yes,
Okay.
sir. Yes, sir.
You're not talking to a lay person or a patient's relative.
Correct.
Be careful when you talk, because some examiners may get offended.
Yes, sir.
It's very important to measure the peak RBLV ratio.
Yes, sir.
And what is acceptable?
Sir, acceptable is 0.7, sir.
Yeah.
How do you
We-
measure?
Sir, we measure with the left side, we already have an arterial trace, and with the right side, we put a catheter with the syringe needle into the right ventricle, sir. And the ratio of both is taken, sir.
These days it's done through a DE, you know.
Sir?
These days you go by the T, you know.
No, sir. We still do, sir, in most cases with syringe and catheter based.
Why catheter? We always used to put a needle which is connected to the line, and
That's
then
what, sir. That's what, sir. Sorry,
yeah,
sir. That is what I'm trying to say.
not then
Not
you have
catheters.
the low RV, mid RV, upper
Yes, sir.
RV, PA,
Yes, sir.
no, then you get into. And the aortic pressure is taken as the cardioplegia needed pressure, you know, it's taken like
Yes, sir.
that.
Yes, sir.
Mhm. Many years ago, previously, we used to do a long needle put from the anterior part of the right ventricle, take RV pressure, then pierce the septum, go to the left ventricle, and I think that's all given up. You know, this is historically to measure the peak RBLV ratio.
Yes, sir.
I think 0.7 is accepted. Our time we used to say 0.8, but now most surgeons accept 0.7.
Yes, sir.
Yes, sir, that's the upper limit. Yes.
And of course, you have to take it soon after coming bypass and also before, because as time goes on, sometimes it falls, you know, because the patient had a long cardiopulmonary bypass, cardioplegia, and so on, you know. So, and it may still fall in the post-operative period, you know.
Yes, sir.
TA, if you have to do a TAP, how much will you go above and below?
Uh, no, sir. I want to. Uh, I don't know what how to tell that.
You ask Dr. Sujit, he will tell you.
So, so depends on how the LPA origin also is. Okay. So usually the origin of the LPA is slightly, sometimes it is slightly narrowish. So usually when we open when we put a transalveolar patch, we go up until the ostia of the LPA. That is the distal extent. Okay, and the proximal extent is as much as you can limit it. Okay, it should be just enough for your uh, pass your full size plus one Hegars. Okay,
Okay.
so gone are the times where you put a huge tab. Okay, because it has to be a ventriculotomy which is just adequate for you to resect all the muscle bundles and pass adequate size Hegars. Okay, bigger the tab, more problems, more RV dysfunction. The patient is going to get stuck more in the
Yes,
ICU
sir.
because of RV dysfunction. Okay. So distally we would go up until the ostia of the LPA, and proximally on the ventricle side we would just you start the ventriculotomy and see how much you need. You would try to resect out whatever muscle bundles you need, maybe about
Yes, sir.
a centimeter and a half, and see if you're able to clearly see the inflow from there. And if you feel that it is still not adequate, you slightly extend it. So like sir
Yes, sir.
said, you measure thrice at once. Okay,
Yes,
so
sir.
it's not like you do a ventriculotomy at one shot, and so you go about say half a centimeter each time and see how much you actually require. Because once you cut, you can't go back.
Yes, sir.
You can't undo it. So basically, so that is what it is. And the smaller it is, the better it is. Okay, but at the
Yes.
same time, you should not have a gradient. So it's like a fine balance between uh, clearing the outflow tract obstruction and also at the same time to prevent RV dysfunction in the long run because of very large ventriculotomy. So, and
Yes, sir.
sometimes what some surgeons also feel that when you're putting a tap, leaving some gradient is also beneficial to prevent RV dysfunction. Because if you're going to put a tap, there is anyways going to be free PR. Okay, so free PR is
Mm.
going to cause volume overload to the right ventricle.
Yes, sir.
Okay, so and this is a ventricle which was already pressure overloaded because of RVH. Okay,
Correct.
so you're essentially inducing volume overload onto a
In a
pressure
pressure
overloaded
overloaded ventricle.
pressure loaded ventricle.
I don't know whether
In
you.
the immediate post
Yeah. Come on. You say finish
is
it.
to yes, sir. So the only way to prevent very severe RV dysfunction in some cases is to not restrict too much, like just enough for you to pass
Yeah.
adequate Haggars, and
Yes, sir.
sometimes even some little bit gradient like 30, 35 is also acceptable.
Okay.
Yes, especially for very small kids, like less than 1 year, 6 months, and all, or infant TOF when we operate.
I don't know whether you've seen a book by Kirkland and Karp on tetralogy surgical aspects in 1970. I don't know if it's available. Such a
Oh,
fantastic book, actually,
yes, yes,
which describes everything, how to close uh, BT shunt of a right side, right aortic heart on the right side, left aortic heart on the left side, each one, how it is closed, and also about the presence of pulmonary arterial origin stenosis, as Sujit said, because very often the left pulmonary artery, there may be stenosis of the origin. So for that, they can put a patch. And Kirkland, that book says if it's a right pulmonary artery origin stenosis, it detaches it from the main pulmonary artery, enlarges it by putting a
yes,
patch and then reattaches. I don't know whether
yes, sir.
these are all
Yes, sir.
practical, but that book is a fantastic one. I don't know whether you got
Yes,
it. It's by Kirkland and Karp, Robert Karp.
Is it available in CMC library, sir?
Yeah, yeah. We all had copies. I don't know what happened.
So
yes. We
maybe
would
if
like to borrow. Yes,
some of you should get
Yeah.
in touch with those people
Yeah.
and then get a copy.
Mm.
Yes, sir.
best would be to scan it and make an ebook out of it and circulate it.
Yes, sir.
It's exactly like what I said about the recommendations of Indian cardiologists, cardiac surgeons. Such a fantastic thing. And nobody reads that nowadays.
Yes, sir.
It's a combined brain of so many cardiologists and young cardiac surgeons in India. Because things are different in Western countries. And okay. So how do you know you've done a good job at the end?
Sir, saturations return to normal. Patient is still in sinus rhythm,
Good.
and
Before you come off bypass waiver, the in sinus rhythm, yeah.
yes, sir. My PRVLV ratio is 0.7 or less. A range of 0.3 to 0.7 is acceptable.
0.3.
Point three is is too much.
It's
It's
disastrous. And not disastrous. That's very often happens when you restricted there's too much and you put a big patch. Otherwise, 0.3 doesn't. No.
Yes, sir.
Okay.
Will you put more pacing wires coming off?
Sir, yes, sir. For all cases of TOF, 2 RA and 2 RV pacing waves.
Yeah, don't forget that.
I don't know if it's relevant for them, sir, but there's a huge discussion with respect to whether we should put a small valve mechanism in the tap, sir, like monocusp
Yeah.
versus
Monocusp valve.
versus. It's a
Mm.
very heavily debated topic,
Yeah.
especially among the pediatric cardiac surgeons communities. So because there are advantages and disadvantages to both. So so I mean, just for benefit of all residents who are here. So with the monocusp, what happens is the initial post-operative period becomes a little easier. That is the advantage. So because there is no free PR, so the RV doesn't take too much of a hit. Uh, so the child progresses through the ICU faster. Uh, okay, so that is the only advantage what we get with the monocusp.
Mm.
But in the but the disadvantage with that is if you don't do it rightly, the monocusp itself can cause an obstruction in the immediate post-op.
Yeah.
And so immediate, and also in the long run, that monocusp, depending on what material you've used, can calcify and cause further obstruction. So that is with the monocusp. And so without a monocusp, initially the problem with not having anything is that there is free PR, and there can be low cardiac output and RV dysfunction, which will need little more time for the RV to recover in the ICU. Yes, but in the long run, I mean, there won't be any obstruction. But later on, they will need a some like in adulthood or adolescent age group, they'll need pulmonary valve implantation.
Yeah.
So which has its own criteria. I don't know if we can get into it or not because it's
Maybe
Many
another.
years.
Maybe next class we should discuss about the reoperations, the indications for reoperations, and what you're going to do. Maybe because tetralogy is a very important topic, and all of you will get a case, definitely get a case. So
Yes, sir.
maybe we should do that next class. I think it will be too much for today.
Right,
We're
sir.
already at 8:25.
Many years ago, we used to do this monocusp, and I didn't find it very helpful. But the only thing we used to insist that it should be positioned exactly, the large monocusp, so that it hits against the reserved other cusp of the valve. And the other thing is that I think we should discuss the indications of shunts. What are the shunts available? Which is the best
Yes,
shunt and other. That we have
yes,
not
sir.
discussed. That's very important.
Yeah,
So
Sure.
that's a
palliative
huge
procedures and
Yeah.
reoperations.
And the
yes, sir.
new procedures like ductal shunting and RV outflow shunting, because
Yes,
in the original recommendations of cardiology, they said uh, less than 2.5 kilogram shunt, but it's a very difficult to have a properly uh, made uh, planting at that stage. You can either overdo it or underdo it.
underdo it. Yes,
So
sir.
that's why they have gone to all this video hunting, and which is easier. And I think we should discuss all those things in another
Yes, sir.
class. I think.
Yeah.
Yes, sir. So TOF by itself is very vast,
Yeah,
sir. Like,
yeah,
70% of our work is all only TOF.
yeah,
So, I mean, if TOF, if they know a little bit about TOF, then most of the pediatric cardiac work is covered. Like,
yeah.
most of, because that covers the huge chunk of conotruncals, sir. So,
Okay,
that's
Okay,
I
sir.
think we will stop here.
Uh,
Thank you,
Okay.
sir. Thank
thank you,
you,
sir.
Okay.
Dr.
Thank
Sujit.
you.
Thank you, sir.
Appreciate
Thank you,
your
sir.
participation.
Thank you, sir. Thank you, sir. Thank you. My
Right.
pleasure.
Thanks.